Okay, so let's talk about ivermectin and COVID. Over the past couple of days, several of my friends have asked me about ivermectin and COVID. And then last night, a friend of mine sent me this video of Dr. Pierre Corey giving a talk in front of the Senate hearing about ivermectin. And so I watched this last night,
And
and
as a prophylaxis agent, it is immensely effective. You will not get sick. You will be protected.
so he makes statements like that throughout the hearing, where he states that ivermectin is uh, basically a wonder drug that's going to um, revolutionize COVID-19 treatment. So the hearing itself, I think, was pretty dramatic, and he said a lot of things that sounds more of like a sale pitch than a scientist talking. But I wanted to kind of look into it because it's a legitimate thing to look into and see what the evidence for or against ivermectin was out there. Now, I think everyone comes into these decisions with some kind of bias, and I, of course, have a bias like everyone else. And so I'll let you know what my bias is. I am kind of philosophically a treatment minimalist. I don't think that we should use medications unless necessary. I personally have, taken antibiotics once in my entire life, and I don't think I've ever taken even Tylenol. I've taken maybe ibuprofen once. Um, and then also, I'm kind of a skeptic and a contrarian. So I come to most claims with a very skeptical mindset. And when someone says something, my first impression is not like, oh, that sounds reasonable. My first impression is how are the ways that what this person is saying could be wrong. So anyway, with that, I don't know hardly anything about ivermectin other than what I remember from medical school is that ivermectin is a anti-parasitic drug. It's commonly used in the veterinary setting against roundworms. So, okay, that's the first thing I would do is look up ivermectin because I don't really remember too much about it. So let's look it up. So ivermectin, if you look into it, there is the WebMD page. There is a thing about it's an old 2011 article, and then some uh, website from the NIH about treatment guidelines. Oh, and here's an interesting one. There is a Nature review article about ivermectin. Okay, so let's briefly look at these papers. Okay, so this is a paper from 9 years ago talking about ivermectin. Evidently, ivermectin was discovered in the late 1970s in Japan, and it's been used as a veterinary drug. So we kind of, I think, if you have dogs or horses, you've probably given them ivermectin at some point. But I'm not an internist, so I have never prescribed ivermectin, but I assume it's not used widely in the United States because parasites are not much of a problem in the United States. But I know worldwide, ivermectin is probably widely used. It looks like here they're saying that it is used to treat a variety of um, infections, including onchocerciasis and I can't pronounce this, strongyloidiasis, Ascaris are roundworms, filariasis. Yeah, so bunch of parasitic drugs, which are parasitic drug diseases are very common outside the developed world. So let's look at what this says. This is the NIH COVID treatment guidelines. So yeah, it's an FDA approved drug. So this is an old drug since 1970, so been around for 50 years. Um, okay, so proposed action, they inhibit nuclear transport proteins, which are part of the intercellular transport process that viruses use to hijack and enhance infection by suppressing the host antiviral response. Directed agent, it's likely the basis for its broad spectrum activity in vitro against viruses that cause dengue, Zika, HIV, and yellow fever. So in vitro, it shows activity against these things. But what you'll notice is that ivermectin is not a drug that we use to treat HIV, although in vitro it has activity against HIV. That's something interesting to note. Okay, so here's their data. So they have lots of good references here. I think we should come back to this and kind of look at this further. So I'm going to close this down. Okay, and then this is a systematic review. So I'll accept cookies from the Journal of Antibiotics. This was published in June. Let's see what this is their abstract. Let's see what they say. So several studies have reported antiviral effects of ivermectin on RNA viruses. So this is what the NIH website had talked about. HIV and SARS 2, COVID-2. This is the virus that causes COVID-19. So there is some mechanistic information that would lead you to believe that ivermectin may have some clinical activity against COVID-19. Okay. So here you go. The two people that discovered and developed ivermectin won the Nobel Prize in Physiology and Medicine 5 years ago for their discovery of ivermectin. Okay, so in this study, they looked at all the PubMed data up until April of 2020. So in COVID times, that is like prehistory. So they're missing, this systematic review is going to be missing a lot of the more recent data after April because there's new information about COVID treatments on basically a daily basis. Okay, so they looked at it. They found an in vitro study where the infected cells in vitro. In vitro means in a lab, in a petri dish, or in cell culture, not in a human or in an animal. So they were exposed to 5 micromolars of ivermectin for 48 hours, and they found a 5,000-fold reduction in viral RNA. So that's pretty impressive. That's a dramatic decrease in viral RNA. And it killed almost all viral particles within 48 hours. Okay. All right, very good. Okay, Zika, we don't really care about that. Dengue, whatever. Okay, these are all the other drugs, all the other viruses. And, it probably if we read this, it would show activity against these. Well, here's just out of interest, since HIV is something that everyone knows about. Let's see what it says about HIV. Okay, so 20 to 50 micromolar ivermectin. So what is the dosage compared to so they used 5 micromolar for the COVID-19 study. So this is 10 times higher in HIV. So HIV required a lot more for it to be effective in vitro. Okay, so this systematic review basically is looking at only in vitro studies. There was no human studies. So this is just basically, this paper would say there is mechanistic data to suggest that it may have some clinical activity, so it's worth looking at. I'm guessing that's what they're okay. So here's their conclusion at the end. The blood levels of ivermectin at safe therapeutic doses are about 20 to 80 nanograms per milliliter. So you can't give ivermectin at higher dosages than that, or else it becomes toxic to people. And so the in vitro activity is in the microgram range. So micrograms are basically 1,000 times more than nanograms. So the to get the same activity that you would get in vitro, theoretically, you'd have to give about 1,000 times more than the safe therapeutic dose, so beyond the toxic limit generally, according to what we know about pharmacokinetics in people. So that's interesting. Okay, so now we have a little bit of background about what ivermectin is and some preliminary information. So the next thing I do, I go to PubMed. PubMed is a great resource that indexes all the peer-reviewed literature in the health sciences, and it's freely available to anyone. You can search here. So let's search for ivermectin. Okay, so look, so lots of people have been looking at ivermectin and COVID, so they suggest that. Let's go to it. Okay, so there's 99 results left on there. Now, remember, peer review takes a month and sometimes multiple months to get published. So there is definitely a lag before it hits the peer-reviewed literature. So let's just peruse some of these things. All right, let's look at some more review ones. Okay, this is just letters. Actually, this is kind of an old article from April, so we won't look into that. All right, that looks interesting. This is one from November. Okay, we already know about this. Okay, so I think we'll just kind of peruse these things. Oh, okay. Okay, this is just a comment thing there. Yeah, also just a comment there. Okay. I think this is the paper we just read. Okay, so not interesting. Okay, so this is a prophylaxis trial. Okay, let's peruse it. Although I think at this point, now that a vaccine is available, a vaccine is a prophylactic drug or a prophylactic treatment, and so anything that is going to be used as a prophylactis would have to be superior in efficacy and side effect profile to a vaccine, which I think will be pretty hard to do because the vaccines that we have available now are supposedly 95% effective with no serious side effects. So you'd have to have a drug with no serious side effects that's better than 95% effective. So let's look at this. Single center, double blind, randomized placebo controlled superiority trial with 2 parallel arms. Okay, so this is probably a good study design. Okay, so patients will be randomized to receive 400 micrograms per kilogram of ivermectin, placebo. Okay, so 400 micrograms per kilogram. Let's see what that dosage is compared to the dosages that we normally use in parasitic drugs to see if that's significantly higher or lower. Okay. Ivermectin dosage. Okay. Okay, so Mayo Clinic, probably a fairly reliable site. All right, so for river blindness or onchocerciasis, they are saying the usual dose is about 150 micrograms per kilogram. So in this trial, they're using 400, so that's a little bit more. And for this other disease that I can't pronounce the name of, it's 200 micrograms. So the dosages that they're doing in this trial are about double to triple the usual dosage that you would give for treating parasitic infections. Okay, so um, higher, and I don't know if that is how big the therapeutic window for ivermectin is, but it is a higher dose. Okay, so their study population is patients that have tested positive by PCR but are not high risk. So these are probably younger patients that have no significant comorbidities because they're going to basically not treat them, it looks like. So this is the exclusion criteria, obviously, if they're allergic to ivermectin, or hypersensitive, or if they have any severe disease. Okay, so they're going to check their viral loads of these patients. Okay, so this is just a paper talking about a trial that they're starting up. They haven't done it. There's no data on here as at the time of this published thing. So, okay, not super interesting because, I think this study is now moot because we have a vaccine. And I doubt that this is going to be better than 95%, but maybe it will be. No abstract. All right, here's one fairly recent published where they say that they did not find any efficacy in standard doses. All right, so let's look at this. See if we can find the full free text. That. Okay, so they're saying that they retrospectively looked at it. The retrospective studies are prone to a lot of selection bias and problems, so we can't read too much into them. Okay, so let's see, how many patients have they? Get to the results. Okay. During the study trial, a total of 13 severe COVID-19 patients receiving immunosuppressants were treated with ivermectin at 200 micrograms per kilogram. So that is about the standard dose that we would give people. Remember, it was 150 to 200. In this group, about a third of them were also treated with a monoclonal antibody and with high dose steroids, and some of them had both. Some of them had this drug. I don't know what that is. So all the patients received hydroxychloroquine and azithromycin. For a while, that was a fairly widespread treatment. Remember, there was all this excitement over hydroxychloroquine, how that was a miracle drug early on into this thing, and further trials have shown that hydroxychloroquine is probably not effective. Definitely not effective in the severe setting, and probably not effective early on either. So in the control group, instead of ivermectin, they were treated with antivirals. Okay, Okay, so they had 13 in each group. Ivermectin group was a little younger. Yeah, so if you look at the groups, um, rates of discharge, rates of hospitalization, and rates of ICU are very similar between the two groups. So they're basically saying ivermectin did not seem to help that much. Okay, so obviously, they note study has limitations, retrospective design, could be sampling error. The treatment regimens were not, all uniform throughout, and their study numbers are pretty small, actually, 26 patients total. Okay, but in that study, didn't show any efficacy. Okay, this is another prophylaxis study. I think that's not super important at this point. Okay, this is just another study design. Okay, so all the currently peer-reviewed information probably is not um, showing anything, but peer-reviewed papers lag the current data. So, okay, that gentleman that was giving um, the talk at the hearing was Pierre Corey, COVID. Let's see what this group that he's part of. I think it's this group right here. Yeah, this is the group. Okay, so here's a video of him. Okay, so medical evidence. So this is their group. This is their group that is talking about. So ivermectin. Okay, here we go. So this is their document where they've compiled all the information that supports their position. So in the background, they talk about how let's see, let's make this a little bigger. Okay. So they realize that so they're doing a good thing. They're looking at the literature and trying to find things that would be helpful in treating COVID-19. And they realize that based on a series of negative published trial results, and particularly the Solidarity trial, um, this virtually eliminates any treatment role. So yeah, so remdesivir, hydroxychloroquine, this antiviral, interferon, convalescent plasma, monoclonal antibody therapy. So they're saying that in their opinion, the published therapeutic trials have shown that none of these actually work. Which, yeah, it's true. Like remdesivir, initial clinical trials showed that it was probably effective, and then as we got more data, we found that it's probably not that effective. The effect was not very large. Hydroxychloroquine, same thing. There was a lot of excitement early on in the in the pandemic, and then you guys know that there was all this news of all these people who were saying hydroxychloroquine is the wonder drug that's going to fix it. Well, now we know that's probably not the case, and these guys agree with that. And then convalescent plasma got a lot of press. That turned out to be not that great. I think the jury's kind of still out on the monoclonal antibody therapy. Um, all right, so they're going. All right, so I think they have this protocol. They're calling it the Math Plus protocol. Okay, so here it is. This is what they're coming in with. So this is their point by point logic for why ivermectin is good and why they propose that we should use it. So since 2012, multiple in vitro studies have demonstrated ivermectin inhibits the replication of many viruses, including influenza, Zika, dengue, HIV, others. Okay, so we looked at that, and that's true, all true data. A couple of things to note is in vitro data rarely translates to clinically relevant therapeutics. There are so many things that work in vitro that do not work in actual patients. I come from a cancer background. There are a million things that cure cancer in the laboratory, and they don't work in people. So these in vitro studies are very important and good in basic science studies to do, to give you kind of some information and some ideas of things that you can pursue in the clinical realm. But they do, like working in vitro does not prove that it works in people, not even close. And we saw that based on blood concentrations, the concentrations that you would need to replicate the effects in the lab are 1,000 times more than the therapeutic dose. Okay, but interesting. I mean, it's good that there is in vitro activity. Ivermectin inhibits SARS-CoV-2. Yes, okay, fine. Ivermectin has potent anti-inflammatory properties with in vitro data demonstrating um, profound inhibition of cytokine production and transcription of NF-kappa B. Okay, so great. That's more in vitro data. There are lots of agents with potent anti-inflammatory properties. I mean, that's why we give high-dose steroids to these people, because steroids are basically one of the most well-studied anti-inflammatories. So that's good. That's all also interesting. Okay, ivermectin significantly diminishes viral load and protects against organ damage in multiple animal models when infected. They give two references. Okay, so when they give references in these things, what I like to do is I like to open another tab with the same thing. Basically scroll down to the references. Here's the references. Okay. So that's 32 and 33. 32 and 33. So these are both non-peer-reviewed preprint servers. Okay, so we can briefly look at them. Okay, so this is coronavirus model. So in this case, they used a virus that they found that was similar to the SARS-CoV-2. So they used the mouse hepatitis virus. So that is a coronavirus that infects mice, and they treated them with ivermectin. And basically, the ivermectin treated animals did better. Okay, great. Again, hasn't been peer reviewed. Peer reviewed doesn't mean that it's true. It just means that at least a few other people that know about this field have looked at it and decided that, in their opinion, the conclusion are reasonable and the way they did the study is reasonable. When it hasn't been peer reviewed, that means someone just wrote something and put it on a website. It has undergone zero critical analysis. But it doesn't mean, I mean, this may eventually get published or it may not. And there may be major flaws in the study or there may not. I don't think it really matters in this point because it's an animal study. And animal studies, again, so like coming from the cancer therapeutics world, the universe of things that work in vitro is ginormous. It's huge. There's a gazillion things that kill cancer in vitro. And then the universe of things that work in animal models is quite large. There's a lot of things that they work great in animal models, and then the number of things that work great in people is extremely small. So working in animal models is definitely one step up from in vitro, but does not mean that it works in people. So same thing, this is in a hamster model. Great. So that's good. Okay. Ivermectin prevents transmission and development of COVID-19 in those exposed to infected patients. So they're saying that it's a prophylactic drug. Okay, so again, prophylactics are useful if we didn't have vaccines, because vaccines are a prophylactic drug as well. And so you would have to show that it's better than a vaccine. And as we know, the vaccines are 95%. And the vaccines were done in a double-blinded, randomized control study with like 40,000 people. There's like no level of evidence better than that. So let's see. I'm just curious what their level of prophylaxis protection is. 34 to 36. Yeah. Okay, a matched case control study. So again, not peer reviewed yet. Doesn't mean it's a bad study, just means it hasn't been looked at critically yet. Okay, so healthcare workers were matched to 186 case controlled pairs. So they try to match them by age, gender, profession, and date of diagnosis. So good. So instead of randomly dividing them up into two groups, they try to match them to be similar. The ivermectin prophylaxis was taken by 77 controls and 38 cases. 2 doses were associated with a 73% reduction. Okay. Okay. So they said that at a dose of 300, there was a 73% reduction. So not a 95% reduction, 73% with some fairly high doses. Interesting, but not. I mean, at this point, if someone's going to ask you, do you want to just take ivermectin? And I don't know how often they did it. Let's see. Okay, so monthly. So 2 doses and then monthly, right? 2 dose ivermectin associated. 1 month, those are involved. Okay. So it seems like you'd have to take it monthly, possibly. So would you take ivermectin monthly, or would you rather get a vaccine? I think most people would say, I'm going with the vaccine and 95% rather than ivermectin. Okay. Ivermectin hastens recovery, prevents deterioration in patients with mild to moderate disease treated early after symptoms. Okay, so here's the thing about mild to moderate disease treated early after symptoms. We know that COVID-19 is a pretty mild disease in the vast majority of people. Overall fatality rate is probably less than 0.5%. So in that group, when you treat people early, everyone's going to do well. I mean, you could give people carrot juice and they're going to do well. Because if you give them nothing, they're going to do well. So in that setting, it's really hard to prove that something is doing better than doing nothing. Now, if you have a disease where everyone does really badly, then it's easy to prove that. But it's hard to improve on 99.5%. So I think saying that you're going to treat early to mild disease with ivermectin, it's just not a very strong argument, because the disease itself, if you did absolutely nothing and treated them with nothing, in the vast majority of patients, they're going to do well. So I don't know, like if me personally, if I got COVID-19, um, I'm not going to be too amped up to take ivermectin, because I figure I'm going to do well anyway. And ivermectin's probably very safe. Let's look it up. Let's see what the side effects of ivermectin are. Ivermectin side effects. Because even the safest drugs, like Tylenol has side effects. Tylenol kills some people. In fact, I think Tylenol kills more people than any over-the-counter drug. Okay, so WebMD, they're probably pretty reliable. Mayo Clinic, sure. Drugs.com. Okay, yeah. So let's look at these 3 websites and see what kind of side effects you can expect from ivermectin, or are possible from ivermectin. All right, so headache, dizziness, muscle pain, nausea, diarrhea. Okay. Joint pain, tender, swollen lymph nodes, dizziness, neck pain, chest pain. Okay, you can get confusion, seizures, loss of consciousness. Okay, so those are very rare but very serious side effects. So, these are potentially things that could happen. And then you can get an allergic reaction. You can get an allergic reaction to any medication. People can get allergic reactions to the to the vaccine that's being rolled out right now. And so people that have severe allergies are recommended to be careful or to not get it. So that's not anything that, allergic reactions are something you can get with any medication. But that's not a knock against ivermectin in particular. Okay. So this is okay, so fever, skin rash, joint muscle pain, swollen glands, rapid heartbeat. Okay, so here we go, healthcare professionals. So here's the part where they kind of get a little more specific about the side effects. Okay, ivermectin is well tolerated compared to other things. Adverse reactions, pruritus, itchiness, fever, rash, myalgia, headache occur commonly. So those are pretty common reactions. So that's not, you kind of expect some of this to happen. Okay, you can get some blurred vision, conjunctivitis, keratitis. All right, so that doesn't sound very good. Worsening of Mazzotti reactions. Okay, I don't know what that is. Curious. What is that? It's a Wikipedia article. Now, some people don't look very kindly on Wikipedia, but I think Wikipedia is actually very, very accurate in most things because there's so many people kind of vetting the information. If you write something Wikipedia article about some really obscure thing that no one cares about, yeah, it can say anything. But something that is that people are looking for, it's going to be vetted pretty well. Okay, this seems to be something to do with parasitic infection, so I don't think that that is an ivermectin specific thing. Okay, so this is kind of scary. So I'm sure these are very rare side effects, but you could get dizziness, headache, vertigo, tremor, serious or fatal encephalopathy. So that's not good. Seizures. All right, so anyways, clearly not a completely benign thing. You can get tachycardia, PR changes, electrophysiology changes in your heart. So these are not, it's not a benign drug. No drug is a benign drug. So you have to weigh the benefit with the risks. And if you're treating a disease like COVID-19, which is pretty mild in younger people with and does well in most people with no treatment, you'd be hard pressed to say that you should give ivermectin to everyone. Now, if someone ran a study saying that they gave ivermectin to high risk patients only, really elderly people or people with lots of risk factors early on in the disease, and they did well, there may be a case for that. And I think it'd be interesting if they had a paper like that. Let's briefly look at 37 to 42. Case series of 100 causes. This is just a letter. So they did a retrospective study of 325 patients, so it's pretty big numbers, but retrospective study. Remember, retrospective studies are rife with lots of problems, and it's hard to show anything um, unless the differences are huge. Yeah, so So basically, they showed some improvement in people that were treated early. Okay, so 10% versus 45% required extra oxygen. Okay, so 1% versus 8%. I mean, that's pretty good data. But yeah, I mean, basically, in order to prove something, you need this. And they agree with that. Okay, so let's forget what this shows. Okay, so based on the ivermectin at relatively high dose, plus dexamethasone, plus aspirin, that's to prevent hypercoagulation because we know that clotting is a big problem in COVID-19. They don't say what numbers. Am I missing it? Numbers. Okay, so in their study, so they didn't have a control. They're just testing it against the overall mortality in Argentina in their country. Okay, so one patient died, so 1% mortality versus 2.1%. And then 3% of their patients got hospitalized versus 26% in published data. Now, this it's hard to make this. This is kind of a terrible comparison to make because they're checking their mortality, their hospitalization rate versus previously reported, and we know that our treatments have gotten way better. So currently, without ivermectin, our hospitalization rates and fatality rates are much lower than published data. So. Okay, so here's the most interesting thing if this is true. Because the time that you would want to find a drug that's useful is when people are serious. Okay, so this says reduces mortality in critically ill patients. Okay, so 43, 45, 54. So that's also this 43, 45, 54. Okay, so let's look at it. Those are I think these are the three critical papers. 43, 45, 54. 43, right? So this 45 or so they look at charts of patients hospitalized in Florida with confirmed COVID-19 between March and May, treated with or without ivermectin. So this is, again, retrospective study. They're doing chart review. They found 283 patients, 173 treated with ivermectin, 107 without, were reviewed. Lower mortality, 15 versus 25. And then lower mortality amongst with the severe pulmonary involvement, so 40 versus 80. So this is good. Again, the problem with these retrospective studies is you don't know the selection bias of the two groups. Who knows if the 173 patients that were treated with ivermectin just were better, healthier in some way. Maybe they were younger, maybe they had less comorbidities, maybe they had better lungs to begin with. We don't know. So I mean, this is good data. It suggests something. But we had data like this for hydroxychloroquine. We had data like this for remdesivir. We had data like this for convalescent plasma. And in the end, they panned out to be nothing. That's the problem. There's going to be a lot of, oh, well, actually, here we go. This is a randomized clinical trial. Okay, so let's look at this. This is interesting. So this is a study out of Iraq, randomized. So not blinded. So that's the problem. Patients aren't blinded, and the people gathering data are not blinded. So when you're not blinded, that means that the patients know and the doctors know who got the ivermectin and who didn't. So there is some bias introduced by that, because if you want to show that ivermectin is better, there is this kind of subconscious bias that you're going to try to make the data look better. Even if you're not consciously doing it, even if you don't want to do it, you're ethical. That's why most real and randomized prospective trials are double blinded. The doctors don't know and the patients don't know, and they just gather the data, and then at the end, one person who does know puts the key together and they collate the data. And that's how the vaccine trials are. The vaccine trials are double blinded studies. Okay, so they had 18% mortality rate in the ivermectin group and 27% in the non-ivermectin group. Okay, so I think it's definitely worth looking at. And obviously, there isn't, people don't make this much to do about something if there's absolutely nothing to back it up. So I would put this kind of in the same category as hydroxychloroquine. Like, looks promising, lots of preliminary data that support it. Probably needs a large randomized study to show that it works. Now, that being said, if you're critically ill, would I take ivermectin based on this data? Maybe, yeah. Why not? I think ivermectin's pretty safe, and if you're pretty ill, I don't think that unless there's some interaction with ivermectin and the other drugs that are normally given, which I don't think there is, I think that it's worth trying. I definitely would. It's worth trying. I definitely wouldn't use it as prophylaxis because it's not better than vaccine, and I wouldn't use it in the mild early in the disease, because you're just going to do well early, and there's no reason to treat 99 people that are going to do well no matter what and subject them to the side effects of this medication. But in the moderate to severe cases, I think at that point it might be worth it with this data. The data is not definitive, and it probably should be run in the setting of a clinical trial. So I think hospitals that use it should run it in the setting of a blinded prospective clinical trial, so that we can nail down if it actually does work. Because remember, remdesivir actually worked in a prospective trial, but it wasn't big enough, and eventually it turned out not to be that useful. Okay, so anyways, that's how I kind of vet information that I hear about, and just my thoughts on ivermectin. If you have any questions, just comment below. Thank you.